Greetings, fellow investigators of the mind, and welcome. Today, we're cracking open a new case file on one of our most formidable adversaries, treatment-resistant depression. We're going to follow the clues, we'll examine the evidence, and see if a really surprising suspect, one that's been hiding in plain sight, actually holds the key to a breakthrough. So picture the scene. You're with your patient, you've tried the standard protocols, maybe they're in psychotherapy, but things have stalled. The trail's gone cold. You know, it's a frustratingly common scenario for all of us. So where do we even begin to look for a fresh lead?
And make no mistake, the scale of this mystery is just staggering. We're not talking about some rare thing here. Major depressive disorder affects more than 350 million people around the world. So this isn't just a single case, it's an epidemic, and it demands our absolute sharpest detective skills. Okay, let's survey the scene of the crime. The central challenge, the real problem, is that our usual methods, while they're great for many, they leave a pretty big group of people behind. We're talking about a full 1/4 to 1/3 of our patients who just don't respond to our first-line strategies. These are the cold cases that end up on our desks.
Now, when a case goes cold, any good detective knows you have to re-examine the fundamentals, and that's exactly what this study does. It points us to a totally new line of inquiry, the brain's energy metabolism, and it's here, in the world of bioenergetics, that we find our new and frankly very unusual suspect.
So who is our person of interest? It's creatine monohydrate. Yeah, I know. At first glance, it's a totally unassuming suspect. We think of it for sports, right? But it's also a basic molecule our body makes, and we get it from foods like meat and fish. It's cheap, it's safe, and it plays this huge role in powering the brain. It's not the usual suspect for a psychiatric intervention, and that's what makes this whole investigation so compelling.
So let's build a profile. What's the motive? Why would creatine even be involved? Well, first, we know that problems with brain energy are linked to depression. Check. Creatine is also neuroprotective. It shields our neurons from damage. And this is crucial. It seems to modulate the exact neuroreceptors, serotonin, dopamine, that our standard meds target. It's got means, motive, and opportunity.
Okay, with a viable suspect on the table, it's time to move from theory to a full-blown investigation. We need hard evidence. So let's dive into the clinical trial that put creatine under the microscope and see if our hypothesis actually holds water.
So the investigators set up an 8-week stakeout. They brought in 100 participants with depression and randomized them. Everybody got cognitive behavioral therapy, CBT, with regular check-ins, and it all led up to a final assessment at the 8-week mark to see what, if anything, had changed.
And the interrogation was just a classic double-blind setup. You know, the gold standard for getting a clean answer. Here's how it worked. Group 1 got 5 grams of creatine a day along with their CBT. Group 2, our control, got an identical-looking starch placebo. The key thing, nobody knew who was getting what. Not the participants, not the investigators. A perfect setup.
So after 8 weeks of really careful observation, the evidence was all collected, the data was unblinded, and it was time for the verdict. So, what did the investigation actually uncover?
This, my friends, is Exhibit A. This is the smoking gun. Just look at the difference in the final depression scores on the PHQ-9. The creatine group ended up with an average score of 5.8. That's in the mild depression category. And the placebo group, 11.9. That's firmly in moderate depression. The difference here isn't just statistical, it's clinically huge.
And to be really precise, after they adjusted for things like baseline severity, age, and sex, the difference was a drop of 5.12 points on the PHQ-9 scale. That translates to a major, robust advantage for the creatine group. The evidence is just really, really compelling.
But of course, a good detective has to check the alibi and the character of the suspect, right? Was this intervention safe? Well, the safety file is remarkably clean. The number of people who dropped out for any reason was exactly the same in both groups. And the number of people who had at least one adverse event? Also comparable. Our suspect appears to be safe and really well tolerated.
All right, now for the fine print. What were the side effects? Well, mostly they were some mild GI issues, like diarrhea or constipation, and some muscle cramps in the creatine group. But what's really important is that these things tended to happen early in the trial and then just kind of faded away as time went on. And that's vital information for us when we're counseling our patients.
Okay, so we have a verdict. But what does this all mean for us? On the front lines. how do we take this evidence and actually put it into our detective's toolkit for clinical practice?
Here it is, your clinical briefing, your rules of engagement. First, you identify the right patient, someone with depression who is already doing psychotherapy, like CBT. Second, you propose the idea of adding 5 grams a day of creatine. Third, you counsel them properly about those potential mild temporary side effects. And fourth, you just monitor their progress like you always would. It's an elementary yet potentially powerful addition to our strategy.
You know, the authors themselves summed it up perfectly. This was a hypothesis-generating trial. It's not the final word, but it is a powerful first chapter, and it really suggests that creatine could be a useful and safe tool to boost the effects of psychotherapy for our patients.
Now wait a second. Every good detective knows the importance of the case notes, of acknowledging what we don't know. We have to be really clear. This was a pilot study. The dropout rate was high, partly because of the pandemic. The patient population was pretty young and not very diverse. We don't have long-term data, and, this is a big one, we cannot apply this to patients with bipolar depression where manic switches are a real concern. So this case isn't closed, it's just been cracked wide open.
So, the game is afoot. This whole investigation leaves us with a critical question. What other elementary solutions, what other simple, safe, and affordable clues, just like creatine, are hiding in plain sight, just waiting for us to find them for our toughest clinical cases? Keep your eyes open and never stop investigating. Thanks for joining this explainer.